46 Xy Dsd refers to disorder of sex development in individuals with a 46 XY chromosome pattern. This means they have one X and one Y chromosome, which is typically associated with male development. However, in DSD, the development of the chromosomal, gonadal, or anatomical sex is atypical. In simpler terms, individuals with 46 XY DSD may have a male chromosome pattern but develop differently, potentially with female or ambiguous external genitalia. As I've said, 46 XY DSD refers to a group of conditions where individuals with a male chromosomal makeup have atypical development of their gonads and or external genitalia. The etiology or cause of 46 XY DSD can be complex and varied, but generally falls into two main categories. Those are problems with testosterone or dihydrotestosterone production or problems with androgen action. To see common examples or common cause for 46 XY DSD, the first is androgen insensitive syndrome. This is the most common cause of 46 XY karyotype. The body cells don't respond to androgens, resulting in a range of phenotypes from male to female, even with 46 XY karyotype. The other is Leydig cell hypoplasia. A deficiency in Leydig cells, which produce testosterone, can lead to incomplete masculinization. The other cause is 5-alpha reductase deficiency. This condition impairs the conversion of testosterone to dihydrotestosterone, which is important for male sexual development, especially external genitalia. The other is XY pure gonadal dysgenesis, a condition where the gonads, testes or ovaries don't develop properly, leading to a lack of androgen production. Mutations in gene involving androgen synthesis or action can also cause 46 XY DSD. Specific gene mutations can disrupt the pathway involved in testosterone production or utilization, leading to various DSD phenotypes. The specific features of 46 XY DSD can vary significantly from person to person, making diagnosis and management complex. Most of them have ambiguous genitalia. The external genitalia may not be clearly male or female. A penis that is smaller than expected for a male can also present, micropenis. And a birth defect where the opening of the urethra is not at the tip of the penis, called hypospadiasis, can also occur. The other clinical presentation is cryptorchidism or undescended testes, and also incomplete viralization. Not all the typical male characteristics develop during puberty. Other presentation can be primary amenorrhea, absence of menstruation in a female, and increased risk of gonadal tumors. Individuals with 46 XY DSD may have high risk of developing gonadal tumors, especially in the undescended testes. Diagnosis of 46 XY DSD needs careful clinical evaluation and certain laboratory investigations. Clinical evaluation include family history, physical examination, and assessment of genital anatomy. Hormonal measurements such as checking testosterone, dihydrotestosterone, and other hormone levels are important. In addition, imaging studies, ultrasound or other imaging to assess gonadal and other internal organ development is important. In addition, cytogenic and molecular studies are important to identify genetic abnormalities. Managing 46 XY DSD typically requires a team of specialists, including endocrinologists, surgeons, psychologists, and geneticists. So, multidisciplinary care is needed. Prophylactic gonadectomy or removal of the gonads may be recommended to prevent tumor development. In addition, psychological support is crucial for individuals with DSD and their families, as gender identity and social integration can be significant concern.